My name is Puteri Koratul Aini. I will begin the journal club presentation with the introduction and background. Today, we will be discussing a research paper, bone marrow mesenchymal stem cell and mononuclear cell combination therapy in patients with type 2 diabetes mellitus, a randomized control study with 8-year follow-up. So, for this study, there are 8 authors as we can see here. They publish research across a variety of fields. The authors belong to Organ Transplant Institute and Endocrinology Department from the Fuzhou Clinical College of Fujian Medical University, China. The article was published in the Journal of Stem Cell Research and Therapy in the year of 2024. The study was conducted in compliance with the principle of the Declaration of Helsinki and the International Conference on Harmonization Good Clinical Practice Guidelines and Local Regulatory Requirements. There are two problems that become the main reason for this study. Firstly, traditional diabetes treatment for type 2 diabetes mellitus don't work well enough. Secondly, ineffectiveness of single-cell therapy approaches in achieving insulin independence. Ladies and gentlemen, the aim of the study is to investigate the long-term effects of combining bone marrow mesenchymal stem cell with mononuclear cell in the treatment of type 2 diabetes mellitus. The research was conducted to address limitations in current type 2 diabetes treatments. Traditional therapies like insulin and oral medication mainly manage blood sugar but don't significantly improve pancreatic islet function or prevent the long-term complications often seen with type 2 diabetes. Stem cell therapies, particularly using mesenchymal stem cell and mononuclear cells, have shown potential for tissue repair, regeneration, and immune regulation. However, previous studies using these cells individually showed limited success in achieving insulin independence, and the long-term effect remain unclear. By combining MSCS and MCS, the researchers aim to determine if this dual approach could offer better, sustained improvement in blood sugar control and reduce diabetes-related complications over time, potentially providing a more effective treatment option for patients.
One, I will explain about what are new based on our research paper that we choose. The first one is the dual therapy with MSCs and MCs. This combined therapy significantly improve metabolic markers like C-peptide area under CPAUC, which is the curve, and insulin levels. This showing a 50.6% increase in CPAUC after 1 year and sustain a benefit at 8 years. The second one is the reduction in complication, which is the study shows a notably lower incidence of diabetic complication, especially macrovascular issues. In the dual therapy group, suggesting a potential long-term protective effects against T2DM complication. The last one is insulin independence, with some patients in the dual therapy group achieve insulin independent, highlighting a novel benefit and a potential shift toward regenerative rather than solely symptomatic treatment. Next one, I will explain about what are significance based on our research paper. For the first one, it improved long-term outcome, which is over 8 years, patients receiving a combined therapy show better metabolic control and reduced need for insulin, emphasizing MSC and MCS therapy. Effectiveness for sustainable diabetes management is becoming better. The second one is the chronic complication prevention, which is by reducing complications like diabetic neuropathy and angina. This therapy support improved patient quality of life and decrease mortality risk associated with diabetes especially. The last one is the safety profile of the patient, which the study confirmed the safety of this combined therapy with minimal adverse effect and no significant cancer risk, which strengthens the case for MSC and MCS therapy as a viable clinical treatment for T2DM.
Methods. There are few steps involved in order to succeed this research.
First and foremost, patient selection. Patients are selected based on age, which is between 40 to 65 years old, BMI less than 35, have medication with stable dose of insulin and metformin for previous 3 months, and reject patient with renal dysfunction, kidney failure stage 3 to 4, and also pregnant. Then, the study flow. Eligible patients underwent standard medical treatment and randomized into three groups, which are MSC plus MC group, MC only group, and control group. Next, bone marrow collection. The patient's bone marrow was aspired from both posterior superior iliac spine under local anesthesis with 2% lidocaine. Then, MSC culture infused into patient's body after bacteria, fungi, and mycoplasma test has been done and results in negative. Number 5, MC production. After the procedure, MCs were transported for immediate infusion. Next, intra-arterial infusion, where the patient underwent angiography of celiac axis and splenic artery, and after the artery was cannulated, MSC and MC was infused slowly into the patient's body. Number 7, endpoints and follow-up, which frequent checkup had been done for every 3 months. Lastly, for statistical analysis, researchers use computer-generated block randomization using graph by Prism and did the chi-square test and also ANOVA calculation.
The next part is the result of the experiment. The first one is the demographic data and baseline characteristics. So this figure shows the flowchart of patient selections, randomization, and follow-up. But this flowchart is not complete, as it didn't include one information that should have been there to avoid confusions from the audience. So if you see at the top, it says that 132 patients have been screened for eligibility and 96 is eligible for randomizations. And they will be allocated into three groups, which is MSC plus MC groups, MC only groups, and also the control groups. The MSC plus MC groups shows that 33 patients is allocated in there, but only 32 patients that received the MSC plus MC plus SMT treatment, which they didn't include the information about the other one patients that have been excluded, and it is stated in the articles that the other one patient is excluded because of the cerebral arrest. For the next part is the therapeutic benefits. The first one is metabolic controls. In the article, it is stated that um, in the metabolic controls for 1 year and after the 8 years follow-ups, there are six elements, which is C-peptide AUC, which is area under curve, insulin AUC, HbA1c levels, FBG levels, insulin dosage, and also the fasting C-peptide levels. And in the articles, it is clearly stated of the p-values and their percentage, but not all of the data is stated in there, such as in the fasting C-peptide levels. It is only states that after the 8 years follow-up, the MSC plus MC and MC only groups, they have been significantly decreased, but they didn't put the exact data of the amount of the decrement. For the second one is the chronic diabetes complications. In in the bar chart in the article, there have been a little bit of a spelling error, which is in the C bar graph, which they put it in the incidence of the and incidence of, actually it is DRP and incidence of proliferative DRP, but they misspelled it as the incidence of DBR and incidence of proliferative DBR. And in the article, it is clearly shown uh, and elaborated about the information of the first A paragraphs is of the incidence of of my, microvascular complications, incidence of microvascular complications, and also the incidence of DPN, which the incidence of DPN, both of them MSC plus MC groups is lower than their control groups, same as the incidence of microvascular and also the incidence of macrovascular. For the B chart is the among the microvascular complications, which is the incidence of MI, incidence of angina, incidence of stroke, and incidence of amputation. Which incidence of MI, incidence of stroke, and incidence of amputation? It shows that there is no significant difference between the three groups. And the C bar chart is about the microvascular complications, which includes the DN, incidence of DNs, incidence of DRP, and incidence of proliferative DRP, which all of these incidents also shows no significant difference among the two groups. So the last one is the adverse events. The perioperative events also includes the intraoperative abdominal pains, hemorrhage of puncture sites, fever and chills, neutropenia, uh, respiratory tract infections, lung cancer, and gastric cancer. And for the 8 years follow-up, it shows that there is no death for the follow-ups of the patients.
Next, the conclusion. First, the combination therapy of mesenchymal stem cell (MSC) and mononuclear cell (MC) significantly improve metabolic control, including better regulation of blood glucose level, and improve insulin sensitivity. Also, reduce the incidence of long-term diabetes-related complications. Next, the treatment was generally safe, with only mild side effects reported and no severe long-term adverse effect, highlighting its potential for clinical use. Other than that, further research is needed to understand the mechanism behind this improvement, such as studying the signaling pathway involved and also conducting studies with larger and more diverse population that will help validate the result. And we can conclude that the combination therapy of MSC and MC shows promise in providing long-term metabolic improvements and reducing diabetes complications, which is paving the way for innovative treatment approaches. For the critique, I would like to share about the strength and the limitation. The strength on this research is the long-term follow-up, 8 years, provide valuable insight into the sustainability of stem cell therapy for managing type 2 diabetes mellitus T2DM, which is crucial for evaluating lasting effect. Next, the use of two types of stem cell, mesenchymal stem cell (MSC) and mononuclear cell (MC) that enhance therapeutic potential compared to using a single type of stem cell. And also the comparative design, such as the inclusion of control and MC-only group, allow for better assessment of the benefit of combination therapy. For the limitation, the sample size have been relatively small, that limiting the ability to generalize finding to a broader population of T2DM patients. Next, lacks of MSC-only group to compare could clarify specific contribution of MSC in combination therapy, and there is no detailed information about the participant diversity like ethnic background, which could impact the treatment responses.